Dr. Rand, we are back.
Yes, we are.
Ask the Doc. Very cool. Brand new questions all over the world. Very, very cool. I'm glad to be back in Santa Monica to see you today. Thanks for lunch.
My pleasure.
That's awesome. All right, so you get some good questions?
I'm just watching you lie about being happy to be back in Santa Monica. You'd much rather be back in Las Vegas,
No,
except for this visit. You're getting
I
to
love
your
when I come and
friends
see you. I always look forward to see you whenever we get together.
All right, so question number one is, hey Doc, love the videos. Thank you. I had a question about whether or not to block estrogen using an AI. My current doc thinks it's best to let estrogen go as long as you are not having negative side effects, and I've heard the same said by other online. My previous doc wanted to keep estrogen in the sweet spot, and I've heard you talk about this as well. For what it's worth, I feel better allowing estrogen to be higher. I had joint aches pretty bad when taking Arimidex. Reasons I have heard to let estrogen go: it's neuroprotective and protects the endothelial lining in your arteries, so blocking it could raise your risk of heart attack or stroke, as well as other cardiovascular diseases. Also, measuring the blocking of aromatization by measuring serum estradiol would not be accurate, since aromatization happens inside the cells, so you may not really know how much you're blocking. Reasons to block estrogen: high estrogen could cause blood clots, high blood pressure, edema, and could increase the risk of certain cancers. What are your thoughts? I know you are in favor of controlling estrogen. Could you talk about why controlling outweighs not controlling? So
he's been watching the videos.
Yeah, well, the problem is this one's kind of loaded, and I don't mean that like it was ingenuously asked or anything. It's just, there's some. Well, let me just take it one by one. So, yes, I firmly believe that. I think we made that about as clear as I could without being a jerk myself last time, right? You have to block estrogen in most cases, meaning that most people produce, and I've made the argument many times that normal isn't necessarily what we're shooting for. So to keep it within normal limits, I get it. It's not necessarily the best way to treat in some cases. With certain hormones and in certain individuals, yes. But in my experience, keeping it within normal limits is a good idea, because if you don't, with most people, even if it's not most, if it's a lot, they will have symptoms of excess estrogen, including water retention, edema, fat retention, moodiness and irascibility, and we know that certain estrogens in the estrogen family particularly can cause estrogen-sensitive cancers. There's actually a test that's most often used for females, but could be used presumably in males too. You don't need a 2,16 alpha hydroxyestrone test to measure the relationship. You can just look at, and we do oftentimes, the estrone, because within that family we know there's certain estrogens that we know activate the genes for prostate cancer, for example, that all men carry, or estrogen-sensitive cancers in women. So yes, again, we do want to modulate estrogen to a sweet spot, in my opinion. I've seen guys take some of the other advice, and some guys can get away with it. They can have an estradiol sensitive, and I'll get back to why I said that instead of he said estradiol serum here, that's in the hundreds, and they don't have gynecomastia, for example, which is what a lot of guys want to avoid, obviously, the growth of breast tissue. But that's unique. It's not necessarily the norm, but it can happen. And so, you'll hear about, well, my friend doesn't have to take any aromatase inhibitors or an estrogen blocker like a SERM, so I shouldn't either, or I didn't, and now look, I've grown breast tissue. I've seen some, and I might have mentioned this last time, a gentleman with good credentials. It was on a podcast, a very famous podcast, that was talking about how prolactin is the main source of gynecomastia, which, in my experience, in a lot of years doing this, is not the case at all, not even close. As a matter of fact, I've never seen prolactin be the issue, and it's rare you can say never. I've actually won bets with bodybuilders that were taking what they thought were excessive amounts of decadurovaline and nandrolone, and they thought their gynecomastia or nipple sensitivity was due to prolactin, and I said, I think it's from estrogen, and if I'm wrong, I'll pay for your labs. I haven't had to pay for one yet. So I don't know where some of the stuff gets well, from where some people are getting this information. I don't know. I haven't seen any studies, and in my experience is untrue. Now, I talked about well, one of the points I want to make when I was reading this, I was thinking, with so many things, and it goes back to the sweet spot, the poison is in the dose. Yes, if you oversuppress estrogen, you can have issues with achy joints. It doesn't happen a lot, but it happens enough so that it's recognized as a side effect in some individuals. You can also have a lack of sensitivity to the genitalia. You can have other estrogen deficiency symptoms like hot flashes, night sweats, and palpitations. It's not the norm, but it can happen certainly. And with those individuals, you're going to titrate the level of estrogens up a bit. Now, we use estradiol as a surrogate marker for the estrogens, of which we've discovered about 25 or so at this point, maybe more now, I don't know. 3 of which we tend to measure in the human body because those are the major ones. And estradiol is the major one typically, meaning the most prevalent, the highest amount of estrogen. So we use it as a surrogate to measure all the rest. Now, is that always a good idea? Not necessarily. Because some people will be converting a lot of estradiol into estrone. But first and foremost, you can't just look at estradiol serum. That is a measurement typically reserved for measurement of female estrogens because they tend to have a lot more estrogen than males. It's not precise enough to be accurate enough for a male where we're looking for a much smaller number. So I've seen on the same laboratory assays an estradiol sensitive and an estradiol serum, and one was 16, the other was 164. That's how far off, arguably, the estradiol serum can be because it's not precise enough to be accurate. So that might be leading to some of the controversy because you're seeing numbers that aren't accurate, and guys are saying, "Well, look, my estrogen is this high, and I don't have any problems." Yes, it tends to be neuroprotective, as does progesterone and some other hormones. So over suppressing it could be a problem. Under suppressing it, though, can also be a problem for what I mentioned, and he mentions, aside from edema, and I mentioned how it could affect, he mentions certain cancers, not necessarily estradiol, and certainly not estriol, but certain estrones, yes. And I won't review all that. I think people know what I'm talking about, but high blood pressure, it could conceivably raise blood pressure because of the third-spaced water. It would be to a minor degree, but you're holding water. That's what you're measuring in the vessels, but even surrounding them and in the cells, maybe it would have to go back and review the physics of that, but it could definitely contribute at least a little bit. Blood clots, no. That, I believe, and I'm speculating here, where people are getting this information is from the Women's Health Initiative study that showed there was an 8 in 10,000 increased risk of blood clots, but they were using Premarin. And by the way, this is in women only, the Women's Health Initiative. So the excess estrogen was 50% equilin, which is derived from, Premarin is pregnant mare urine, so it was derived from a horse, and equilin, I believe, is 1,000 times more potent on the human uterus, for example, than is estradiol. So yeah, we might have some issues with overgrowth and cancers with something like that. And all the time we've been using bioidentical hormone replacement therapy, using mainly estradiol or 80% estriol and 20% estradiol. It's strictly anecdotal, but we haven't done a Women's Health Initiative type study with that many people with controls, etc. But I haven't heard of anybody blaming bioidentical hormone replacement, specifically the estrogens, bioidentical estrogens, for blood clots. So for a male, particularly since we're dealing with a much lower amount of estrogen, that shouldn't be an issue. But it goes to the point that, if you accept some of this, even because some of it is true, for example, the achy joints and the deficiency symptoms, again, you're looking for a sweet spot. Okay, and yes, you can experience either one of these. He presents both sides possibilities, some of which is true, some of which is not. So I guess more justification for why I try and find the sweet spot, and I'm not the only one. I mean, I believe most physicians out there that do this for a living, and certainly most urologists in the country will want to govern estrogen if they are using a sufficient testosterone dose. And that goes into kind of a whole nother topic here. Maybe you divide this long-winded answer up, but a lot of doctors will look at, and patients will look at the reference interval for testosterone and try and, with replacement therapy, hold the patient within physiologic levels. Well, we've known since the 50s that doesn't necessarily work. With TRT, and I don't have the exact number, I'm estimating, I would say probably for men, for women it's easy, it usually has to be about a 3x of the upper end of physiologic normal. For guys it's about 1.6x. So the reference intervals of normal go right out the window. But my point is, in this instance, if you raise the testosterone to those supraphysiologic levels, you're more likely to have more conversion. So some doctors will say, well, we don't have to do that. And patients will say, yeah, no, I never had to take that. But because they're actually not really on a therapeutic dose of testosterone replacement. So yeah, if you're using those physiologic levels or even lower, certainly below supraphysiologic levels, which typically are not enough for therapy, then yeah, you're not going to have as much conversion, and a lot more people can get away with not having to use something, either a SERM or an AI to, quote unquote, block estrogen. That's a long-winded answer. Should I stop there?
Makes sense, though. Yeah.
But see, so there's a lot of, maybe it's not a loaded question here, but there's a lot of assumption here and presumption here. I definitely recommend controlling estrogen, and there was something else here. It said aromatization happens inside the cell. Okay, but you can still test the serum to gauge the estrogen in the bottom there in the body. There is a relationship there, and the beauty of using an AI is you can actually measure estrogen levels, and you can correlate those with symptoms and signs or not. Whereas if you use a SERM, just blocking the estrogen, because I didn't even mention using something other than AI, or maybe I'm thinking of something else. But it's the preferred method, because with a SERM, you're blocking at the receptor, and you don't know what's working except clinically, and you could be over suppressing, if you will, over blocking or under blocking, and not know it. You're not just looking at a number. In other words, your estradiol sensitive could be 140, but if you're taking, for example, 10 milligrams of tamoxifen twice a day, you're more than protected against that excess estrogen, but you don't know it. It's more of a guessing game. Does that make sense?
Makes sense.
Yeah.
Awesome. Thanks, Doc.
Sure.
What else we got, Doc?
Hey, Doc, you've mentioned somewhere that using steroids in young teen years may crash the boards, and after that, some may never return to normal.
Another one who's watching the show.
Here I am. I used exogenous testosterone when I was 15, and now I can't get back to normal. It's been years. Now I'm on enanthate 50 milligrams every other day. I got my energy back. My morning wood is there more often than not, but my libido isn't coming back no matter what. My testosterone value is 1,250 nanograms per deciliter. SHBG is 16 nanomoles per liter. Estradiol is 140 picomoles per liter. Prolactin 160 micrograms per liter. I also use tamoxifen 20 milligrams every day because that stops my gyno from getting worse. My main issue is non-existent libido. How would you fix someone like me, or it's just over with this for me? Hope you respond to this. Thanks. Yeah, okay.
How old is he?
Well, it doesn't say, but it says he started when he was 15.
It's that, yeah.
Again, we say it up front,
Yeah.
say it during. I can't treat you, and you shouldn't take this as treatment, but this is some information and for consideration as to what it might be, but you should definitely follow up with your doc. Using any sort of hormone, well, let's just focus on these. Using testosterone or an anabolic steroid prior to the complete formation, the establishment of the hypothalamic pituitary adrenal axis, and that's typically, I guess, officially still at age 26, that it's, we used to call it hardwired. Now we think it's more softwired, but it's in place and functioning. There won't be any changes to it, major changes. It's gone through the process of development outside of the womb like humans do. We're not born ready to go. There's still development along the way, etc. And if you disrupt that, then sometimes, it doesn't happen that often, but sometimes you can have a problem. And this is, quick segue to, it's not talked about enough in my opinion, but the same thing can happen when giving oral birth control to females. It's been published, it's been mentioned that, while, you don't want to have a child necessarily at age 16, an unexpected one, unplanned one at least, but you may pay for it down the road by using oral birth control instead of a different birth control method because of that, premature use before the HPA axis has been formed. So anyway, that's definitely possible. Are you out of luck at that point? Not necessarily. Oftentimes you can restore the boards by either using something like, and I don't recommend Clomid, but enclomiphene, one of the isomers of Clomid, to indirectly get the pituitary to send a signal to the testicles to make more testosterone, because presumably it's not a primary hypogonadism. I mean, it's not a problem with the testicles, it's a problem with the signals being sent. So you get your body to do it again, sort of forcibly, either through that, which I would argue is the better way to do it when you're young and you have this sort of problem, than just going with something like HCG, which is what we call a homolog of luteinizing hormone, the actual signal that comes from the pituitary to the testicles to get things running again. So that's an option. I wouldn't necessarily say, oh, I'm out of luck. But when it comes to the other numbers here, there's nothing particularly unusual. You didn't mention if E2 was sensitive or serum, but either way, it's I think that, off the top of my head, was that like 32 picograms per milliliter? I'm totally swagging there, but I think that's within normal limits. But again, I don't know if that's the right assay or not. But at any rate, the issue could be that, and we were talking about this in the prior question a bit, if you have a sensitivity to oversuppression of estrogen, we might have to float your estrogen up a little higher. And that reminds me, the gentleman talked about how he feels better with more. He didn't say how much it was, but yeah, a lot of people do feel better if they are above a certain tipping point at which all of a sudden the wheels fall off and you have the aches, you have the lack of sensation of the genitalia, and therefore you lose the libido, right? I mean, if you can't feel things, well, that's kind of going to ruin the libido, I would think, right? So again, the poisons in the dose, I would consider experimenting with the estrogen to see where you can get to and still stay within normal limits, but maybe restore your libido. I just mentioned HCG. One way of doing that may be, if you're not producing enough estrogen for whatever reason, maybe using HCG, because with an aromatase inhibitor, for example, you can block the formation of estrogen that occurs in fat cells, for example, when testosterone is converted, or in the liver. But with HCG, you're actually producing estrogen before it can be stopped. You're making it directly at the testicular level. So a little bit, I'm saying, but it sometimes helps for libido, particularly with guys that are on TRT and using some of these medications. I know I'm getting way off course here, but I wouldn't say that it's over for you. I would, again, it looks like you're taking plenty of testosterone based upon the numbers, looking at your total. I don't know if this is the lowest it ever goes, but that's a consideration. We talked about needing to have consistently super physiologic levels. The SHBG is obviously very low, so I imagine the amount of free testosterone available to you, you're getting plenty of juice for the squeeze, so that's not the issue. But I would try triggering the estrogen a bit to see what works. 20 milligrams of tamoxifen is plenty. You might consider an AI so you can actually look to see what your actual levels are, rather than just your guessing based upon your symptoms, how much blockage you should have. It'll be easier to titrate is what I'm saying, but consider backing off on the tamoxifen. In other words, you could also consider, if you're sensitive to estrogen in the breast tissue, using a topical formulation of tamoxifen so you get less systemic absorption for the libido purposes, but you're blocking right there at the nipple so that you don't get the gynecomastia, and you try to get the best of both worlds. But does that make sense?
Mm-hmm.
Being able to titrate one without the other, and vice versa,
Mm-hmm.
because it sounds like that might be the issue.
Nice.
But never give up.
That's right.
This one is from a doctor, a neurological surgeon. My wife is a retired 53-year-old IFBB pro figure, but she wants to compete in the 2022 Masters next year. She has been natural all her life, but she is dealing with the effects of induced menopause, uterus and ovaries removed 3 years ago, and difficulty gaining muscle, losing weight, and menopausal symptoms. She has trained weights 5 times a week for many years now. She's on estrogen replacement therapy, estradiol valerate 1 milligram per deciliter. That doesn't make sense. 1 milligram per day. I can't see anymore, but still experiencing hot flashes, some hair loss, and some midsection fat retention. This is her latest body composition test. No one can see this, but percentage body fat is 19.1%. She looks like she's 67 kilos. Anyway, those are probably the most important facts of this. And this is with an in-body, I can't tell which one, but some of these, actually all but the in-body 770, to my knowledge, is using one wavelength and it's impedance testing, so it's using an algorithm to sort of guess what the body composition is. The in-body 770 has 6 different wavelengths that you can get as close as 1%, like a DEXA scan,
mm-hmm.
without getting the irradiation. So just not sure how much how accurate that might be, but that's not what he's asking me. He's asking me, what is he asking? Anything else she should be doing to improve the muscle building and general metabolism to be able to reach competition level? If so, happy to arrange a Skype consult. Not sure he wants to share his name or not, but E. Huertas, MD. So to me, the biggest issue stands out that she's getting estrogen replacement, but as you know, with the ovaries removed, she's not getting any testosterone. And the only place she might be getting it is through the ovaries, producing DHEA and having some conversion to other androgens and eventually, testosterone. So this one's kind of an easy one in that, and this is the problem we were addressing the other day, I think, about, urologists are picking up the ball and running with it for guys, but OBGYNs not so much for ladies. This was standard. You remove the ovaries and they just took care of your hot flashes, night sweats, your estrogen deficiency symptoms, but nobody addressed libido, energy, sense of well-being, joie de vivre, etc. With the testosterone, that's also missing. So again, this one's kind of a no-brainer. For libido, certainly a big part of it can be testosterone. Certainly the gaining muscle, as we know, muscle mass, you still got to do the work. You got to eat right, train right, and sleep right. But to have the leverage of testosterone is very important. When he says losing weight, I'm sure you mean losing fat. Well, put on some muscle, and you'll be burning calories literally while you're sleeping. So, and the other menopausal symptoms he mentions include low T symptoms. So, again, I don't want to ramble on. It just seems like that would be the first thing I would do. Is I would arrange to meet with a physician that is willing to look at these levels. More importantly, just listen to her, because she's 53 years old, and you treat people, not numbers. But she's going to probably get even worse if all you do is supplement with estrogen, because that's going to make her hold water and fat. Also, no mention was made of progesterone. I realize she's had her uterus removed, but still progesterone has other value. So it's not just to oppose estrogen in someone with a uterus. I would consider also adding that, as well as, if she needs it, DHEA, as well as pregnenolone if she needs it. But the hair loss may be due to a thyroid issue first and foremost, and I'm talking to everybody. The doctor who wrote this probably knows this already, but it could also be from the abrupt, even though it was 3 years ago, change in hormones, just the disruption. And maybe she's got an issue where the ratio, either the DHT, which I doubt is going to be that high, but the ratio DHT to other hormones is a problem. But all these hormones need to be rebalanced, not necessarily in a natural way, because even if she had all the original parts, we would be considering treatment here. But they need to be reintroduced, not just one hormone, but all of them, and I think everything should resolve. And of course, I'm happy to go into more detail specifically if you like, but I would also hasten to add that, this is a no-brainer. You could probably, you don't need me for this one. You could go to anybody who knows how to do this medicine and just consider, even if you want to keep it simple, just testosterone, because it's a no-brainer to state that if she doesn't have her ovaries anymore, there's no way, even if she did have her ovaries, most likely at 53 she's producing enough. So this is easy.
Awesome.